I'll invite Dr. Neha, a very intelligent, upcoming oculoplastic surgeon. And she is trained from LV Prasad, and she's going to start the session as an opening batsman in the eyelid session of oculoplasty. Over to you, Dr. Neha.
Good morning, everyone. Apologies for the technical glitch. So today I'm going to be speaking about eyelid malpositions and their management. I am Dr. Neha Ghose, and I've, as of recently, taken charge of the ophthalmic plastic surgery service at Sushila Netralaya. But all of my patients and cases that we will be discussing henceforth is from my parent institute, LVPEI. So eyelid malpositions can range from anything between ptosis, entropion, ectropions, eyelid retractions, and even more complex cases such as anophthalmic eyelid malpositions and traumatic eyelid malpositions. So briefly and in short, this is the cross-section of the lower eyelid. As we know, it is made up of 3 lamella. The anterior lamella is made up of the orbicularis muscle and skin. The middle lamella is made up of the orbital septum, orbital fat, and lower lid retractors. And the posterior lamella is made up of the conjunctiva and the inferior tarsus. And it is extremely important to understand which part of which lamella is actually involved in any malposition so that we can adequately address it. So ectropions can be classified into congenital and acquired types. Congenital is extremely rare. Acquired may be involutional, cicatricial, paralytic, and mechanical. Similarly, entropions can be classified into congenital, involutional, cicatricial, and spastic entropions. So involutional ectropion can vary in their severity. They may either be punctal, they may be medial ectropions without horizontal eyelid laxity. They may have horizontal eyelid laxity. Medial ectropions with MCT laxity. The whole length of the lower eyelid may be involved, and there may even be complete tarsal ectropion. Coming to the more difficult cases, which are cicatricial ectropions, these are characterized by vertical shortening and or scarring of the anterior lamella of the eyelid. They are caused due to thermal or chemical burns, mechanical or surgical trauma, sun damage, or even chronic inflammation. They lead to lag of ophthalmos, which ultimately leads to exposure keratopathy. They may lead to dry eye, infective keratitis, or perforations. The management options of cicatricial ectropion range from myocutaneous flaps to full thickness skin grafts, and may even involve other procedures such as canthopexis, retractor Z-plasties, and even fillers. So the advantages of myocutaneous flaps over skin grafts are they have a better color and texture match due to local origin. They have less postoperative contraction, and they are cosmetically superior because they follow the relaxed skin tension lines. In contrast, full thickness skin grafts have a likelihood of mismatched texture, thickness, and skin color. There may even be graft infection or necrosis, and the chances of recurrence are high, up to 44%. However, there is nearly 100% graft viability in this area. This is a case of a 53-year-old gentleman who had a history of blast injury to the face 4 months prior to presentation. He had difficulty closing eyes, and he had watering since the past 4 months. So he had skin hypopigmentation, scarring, bilateral shortening of the anterior lamellae, bilateral cicatricial ectropion with complete lower eyelid tarsal eversion, and right medial canthal webbing and bilateral loss of eyebrow hair. He also had significant lag of ophthalmos on both sides. The surgical plan was ectropion correction with full thickness skin grafting. And these are the steps: subciliary incision along the length of the eyelid, dissection of the cicatricial bands, retroauricular skin harvesting. We can take skin from anywhere, such as preauricular, supraclavicular, upper arm, or even the opposite eyelid. Graft was sutured to the defect and then divided between the upper and lower eyelids, and then quilting sutures were taken to adhere the graft onto the underlying tissues. This was the appearance on postoperative day 1. Both the wounds were healthy, and at postoperative 2 months of both sides, there was no lag of ophthalmos. And we can see at 4 months postoperative, there was no lag of ophthalmos, improved corneal clarity, and the conjunctiva was quiet. So from this case, we can glean that full thickness skin grafts are useful when surrounding eyelid skin is unhealthy or scarred, and it is effective for 4 lid cicatricial ectropions, such as in these cases, and there is good graft uptake due to sufficient periocular vascularity and small size of the graft. Similarly, in cicatricial ectropion in an anophthalmic socket, this was a case where we did a monopedicle flap, and the patient did well, and a very good contour of the lateral canthus. In anophthalmic syndrome, we have a series of conditions where there is enophthalmos, superior sulcus depression, lower lid retraction, and upper lid ptosis. So in these cases, how do we correct them? There are non-surgical options as well as surgical options. Non-surgical options basically involves adjusting or just modifying the custom ocular prosthesis by placing a bulge at the upper anterior surface to support and increase the height of the upper eyelid. And the extra volume in the upper anterior part and less bulk in lower part also makes the prosthesis tilt forward, thus correcting the upward gaze and improving the aesthetic appearance. We also make it less bulky so that it eliminates the downward and forward thrust and corrects the lower lid ectropion. And a small extension made anteriorly on the inferior part pushes the tarsal plate upwards, so it also reduces lower lid retraction. Surgical options may include fascial slings with or without horizontal lid shortening, lateral tarsal strips, and retractor release and spacer insertions in these cases, such as cartilage, sclera, hard palate, mucosa. Now coming to the entropion, this is a simple case of an involutional entropion. We treated her with a Jones procedure and she did well. If there is too much eyelid laxity, then we can combine it with a lateral tarsal strip, which decreases the chances of recurrence. Now, this is a case which is a very difficult case to treat, intractable, and has a high rate of recurrent cicatricial entropions, where we can see she also has a whole row of distichiatic lashes, more on the right side than on the left, rubbing on the ocular surface. So here we had done an anterior lamellar repositioning, and we also did electroepilation of the distichiatic lashes, and she did relatively well. But these cases are known to cause a lot of recurrence. This was a young boy who had a carbide injury, chemical blast injury, which left him with a cicatricial entropion as well as shortening of the upper lid. So in this case, we had to not only divide the anterior and posterior lamella, but also place a mucous membrane graft and also do a LPS recession to lengthen the medial aspect of the upper lid. So I'll just come to some quick points to remember in ptosis. This is a child with a this is a young girl with a left mild ptosis, and we had planned her for Muller's muscle conjunctival resection, and who is a good candidate for an MMCR. So someone who has mild ptosis, who has a positive phenylephrine test, and also who has a faint lid crease on the contralateral side, so that we don't actually have to go onto the skin at all, and we can just resect the Muller's muscle, and she has, and the post-phenylephrine appearance is an indicator of how she would look after MMCR. So in this patient, this patient had severe ptosis on the right side, and she also had mild ptosis on the left side. We had corrected, she only wanted ptosis correction on the right side. We corrected her ptosis, but this led to the ptosis becoming more pronounced on the left side. So we also have to take into account Herring's law prior to addressing ptosis on one side in such patients. So, and we have to counsel them appropriately that maybe they might have to undergo the correction on the other side as well. So again, if you have severe ptosis on both sides, of course, we can address it together. Sometimes patients want that, but it's always better to do a sequential correction in bilateral ptosis for ideal titration of the endpoint. Tarsal platform show, I'll just quickly finish. Tarsal platform show is cosmetically more significant than the actual palpable fissure height, as we can see in this patient, because even though we corrected the ptosis on the left side, you can see that there is still an increased tarsal platform show on the left side, which the patient was concerned about, and it made her feel that the ptosis was not adequately corrected, even though the palpable fissure height that you can see is exactly the same on both sides post-surgery. So this is a patient of CPEO. I won't go into that, but again, similarly, this is a patient who also had moderate to severe degree of ptosis with extraocular movement limitation resembling CPEO. But we have to make sure that we do ISPAC tests in all of these cases. The sensitivity is about 86% and specificity is about 79%, and the specificity and sensitivity of ISPAC is very similar to single fiber EMG. So we should definitely go ahead and do that, and they also have a high negative predictive value. And this is a patient with a positive fatigue test. So in any of these cases, if there is any amount of doubt, it's always a good idea to go ahead with a diagnostic trial of pyridostigmine, which is considered safe and also resource efficient. Because we have run out of time, I will end the session now. And thank you so much for your patient listening.
Okay, so do we have time for questions, or should
So
we?
we'll
I
do
think
the
we can
discussion
do it
later.
alongside, right? No?
Later, so we
Later?
have time for panel discussion.
Okay,
Yeah,
that's
we'll
good.
continue.
All right, that was a good presentation, and we are getting so super specialized. We have a session on eyelids, and maybe next year we'll have one on the upper lid and the one on the lower lid. So let's, hope for more super specialization. That's good. Thank you.